I want to know what Dr. Byers is on the meeting today. Is he thinking about setting up extracorporeal?
Hey everybody. Stranger things have happened.
Well, good morning, everybody. Welcome to the Extracorporeal Hour, hosted by myself. I'm Jethro Forbes. I'm over at Cornell University, directing our extracorporeal therapies unit here, and Dr. Cedric Dufayet down at UC Davis in San Diego. The Extracorporeal Hour is, as you guys saw in the announcement, and many of you know already, happens every other Friday at 11 o'clock Eastern. And this is a place for us to bring our collective experience, both the successes, both the successes and the challenges. I'm hesitant to use the word failures, but sometimes I feel like that, in a very open, non-judgmental arena, so that we can chat and learn from each other, and maybe offer some guidance, share and take advantage of our collective experience. This is a place where everybody's got a voice. The more voices that chime in, the better. The more faces we can see. We love it when cameras are on. I see a few faces starting to pop up there. It's so much more interesting than names and photos, as cool as all of us are about choosing those personalized photos and avatars. And just as a reminder, if you can't make it to these sessions, each of them are recorded and available through the ACVNU YouTube page. So please do feel free to click on the link to get to the recordings if you miss a session. And if you have an interesting case and want to find a way to crack the ice ahead of time, follow this QR code. This is again available on the acvnu.org IRRR page. We welcome cases ahead of time. Get on the list so that we've got a little bit of prep that we can do. Some folks do presentations and have a more formal PowerPoint. Other folks just bring an idea, a thought, a challenge, whatever it is. This is the place for it. So, with all of that said, I'm gonna turn myself off here, believe it or not, and turn the reins over to Dr. Dufayet, to Cedric, to introduce himself, and then introduce our speaker and expert of the day here.
Yeah, thank you, Jethro. So, it's a very special session for us today because we're lucky to have the corresponding author of the IRIS CRT guidelines with us, Dr. Gilad Segev. I think for most of us, Gilad needs no introduction, but for those who do not know him yet, Dr. Gilad Segev is a professor of vet internal medicine at the Koret School of Veterinary Medicine at Hebrew University of Jerusalem in Israel. Is a diplomate of the European College of Veterinary Internal Medicine, and after being a diplomate, he went on to do an extracorporeal therapies fellowship at a little place called University of California, Davis. He is a world-renowned expert in acute kidney injury, biomarkers of kidney disease, extracorporeal therapies, and I'm probably forgetting a lot of them. He's one of the founding faculty of Hemodialysis Academy. He's been on the board of the IRIS for about 10 years now, I think. And he's also a founding member of American College of Veterinary Nephrology and Urology. So you've probably read some of his papers. You probably know his score to predict the outcome of AKI and extracorporeal therapies. So without further ado, I'm going to hand the floor to Dr. Segev, who will give us a brief introduction of the CRT guidelines, and then we need you guys to come with your questions and interact. The easiest way will probably to put some questions in the chat so we can just detect them and give you the mic, or you can raise your hand with a little handy dandy function in Zoom, and I think Jethro and myself will try to give you your turn as much as possible, and hopefully it will go well. So yeah. So let's not waste any more time and get into the topic, and I will leave the Dr. Segev the floor.
Thank you very much, Cedric and Jethro, for the introduction, and thank you for inviting me here today. This is by no means needs to be or meant to be a lecture. I do have some slides prepared, and so that would be the basis for the discussion, but feel free to just stop at any point, raise your hand or write something in the chat, and or just intervene, and we can discuss some of the aspects that are of interest to you guys. Obviously, the CRT guidelines as the IHD guidelines, which are kind of complementary to each other, these are extensive documents, and they have dozens of statements that you can all refer to in the document, and we cannot cover them all. So I just selected some few topics that would be kind of the basis of discussion, and we can take it from there. So let me share my screen and start the discussion on these guidelines. And then please stop me at any time and intervene if there's something that you would like me to elaborate on. And then if not, we will do some discussion, I guess, at the end of this short presentation. So these guidelines are an effort of a lot of people that you can see here. These guidelines took a lot of time to generate because the way we did that is mostly by discussion. So we met like every week or every other week, and we took one point after the other and discussed each one of these points very thoroughly until we got a consensus among ourselves. And then eventually we send these statements for voting by other experts. Some of them are probably present in this meeting as well. And only those votes that were accepted by at least 75% of the people were accepted as consensus statement. But again, we have like dozens of these statements, and this is not possible to go over all of these statements in a very short period of time. So the first point that we wanted to emphasize and discuss is, what are these therapies? When we say CRRT, what do you really mean? Because for most people, at least we thought, when you say IHD, you mean I'm using an IHD to deliver treatment. And if you are using a CRRT platform or a platform that is designed to deliver a CRRT treatment, then you are doing CRRT. And this is not the case. So this was the first point that we wanted to emphasize. What is really determining the treatment itself is not the platform that you are using, but rather the prescription, and most importantly, how much time are you going to treat. And so we had defined the treatment based on the literature, but also some adjustment that we had made based on the time of the treatment. So if you are doing anywhere between 0 to 6 hours, that's going to be an intermittent treatment. You're going to treat for 6 hours, 5 hours, 4 hours, and then you're going to come back 24 hours later and maybe 48 hours later and do another treatment and another treatment. We had defined a peer treatment between 6 and 12 hours. And 24 hours, we call that transitional CRRT, and I will focus on that in a moment, just to define what we call transitional CRRT. And then if you are treating for more than 24 hours, then you are doing conventional continuous renal replacement therapy. So the first point is, it doesn't really matter which platform you are using. If you are using a platform that was designed for CRRT treatment, like PrismaFlex or PrisMax, and you are treating for 4 hours, and then for the next day you are doing another 4 hours, that is intermittent treatment. If you are now using an IHD machine, or machine that was designed to deliver an IHD treatment, but you are treating continuously for 24 hours or longer, then basically you are performing a CRRT. So the machine itself is designed to deliver a specific treatment, but the treatment itself and the prescription, and specifically the treatment time, is going to define the treatment. Now, what is this creature of transitional CRRT? This is not something that you can find in the literature. And basically what that means is that we are planning to do a CRRT treatment, but we are planning that for a relatively short period of time compared to a real CRRT treatment. And we call that transitional because we intend to transition these patients to an IHD platform if the patient does not recover. So CRRT, continuous treatment for 24, 48, 72 hours is extremely demanding. And if you are doing these treatments, you're probably aware of the huge demand of resources, personnel that you are using in your ICU, in your intensive care unit. And so that's, for many places, is not really realistic to perform these treatments over days and days, like these treatments are done or performed on the human side. And so for us, at least in our setting, because we have the opportunity to both do, we have two platforms, a CRT platform and an IHD platforms, we are transitioning to IHD after a CRT treatment. So in CRT treatment, we try to normalize urea creatinine and restore homeostasis within 12 to 24 hours. And then if these patients are recovering, that is great. But if they are not recovering, you can now do intermittent treatment because, as I had mentioned, to perform a real CRT treatment over 48 over days is highly demanding and often not feasible. Now, again, even if you don't have an IHD platform, you can use your first treatment as a transitional treatment, slowly decrease the concentration of the toxins and normalize them. And if these patients need additional treatment and they meet certain criteria, you can use your CRT platform to deliver future intermittent treatment. Now, we have to bear in mind that when we are using these platforms, not to the purpose that they were designed, they have some limitations. If you are using IHD platform for CRT treatment, obviously there are some limitations. And the main limitation is to be able to provide a very slow treatment because these machines are not really designed for that. And if you're looking at the CRT platform, they are not really designed to deliver an IHD treatment because some of them, or for at least for big patients, large dogs, you cannot deliver the treatment at the desired or adequate dose of the treatment. So these machines have limitations. But the first point was to make was that the treatment itself is defined not by the platform, but rather by the prescription. And so on one hand, we have intermittent treatment. On the other hand, we have true CRRT treatment. But we also have this creature of transitional CRRT, which means around 24 hours treatment to restore homeostasis and transition these patients to an IHD platform. The indications, I'm going to skip that because these indications are not different than the indications of IHD. Shortly, we are now considering dialysis when creatinine concentration is increasing 5 milligram per deciliter and trending up. In the past, we talked about creatinine concentrations, but we know that in higher concentration of creatinine and when the body is exposed to high concentration of uremic toxins, multiple organs are affected. And so despite our ability to decrease safely the concentration of these toxins using each one of the platforms that we have, the damage had already occurred to these organs and are not likely to recover very quickly. So even if we can safely decrease the concentration of these toxins from creatinine of 15 or 20 back to the normal reference range, that does not mean that all the organs can now recover very quickly. So what we are trying now to emphasize is that we need to intervene soon enough to prevent this organ damage and not really to only treat the azotemia and then deal with the organ damage that already exists in these patients. So we know that when we intervene sooner, the outcome of these patients is better. It has been demonstrated multiple times on the human side, and we also see that in our patients. The number of organs that are already affected by the uremia is highly influencing the prognosis and the outcome of these patients. So we highly recommend consider dialysis and intervention at earlier stages of the disease. Another slide that's just to put here, but not really very new, is the priming volume as part of the prescription. We know that we always need to assess the circuit volume in relation to blood volume. And ideally, we would like to have these patients have an extracorporeal volume of less than 10% compared to patient blood volume. We know that in our veterinary patients, this is oftentimes not feasible. We know that most of these patients can tolerate up to 15% of blood volume outside of their body without substantial complications. But every time the blood volume is exceeding 20%, we now need to consider these patients as having high risk of hemodynamic disturbances, and we need to think of the priming volume, whether we're going to use colloids or blood prime volume. This is a specific consideration for each one of these patients. And again, when we say 10% or 15% or 15 to 20%, this has to be individualized. Some patients can tolerate higher extracorporeal circuit in relation to blood volume, and some patients will show hypotension even if the blood volume is not exceeding 15%. But these are kind of general guidelines. Most patients will tolerate an extracorporeal volume that is 15% or lower compared to their blood volume. And if it's above that number, we need to consider other colloid support. As far as modality selection for CRRT, we always select the modality that will give us the highest flexibility during the treatment. And this is machine specific, but in the Prisma and Prisma Flex, if you are selecting this mode of CVV HDF, that will give you the flexibility to do hemofiltration, hemodialysis, and combination of these two options. And so it would be better not to limit yourself when you are selecting the treatment, because oftentimes when you do so during the treatment, that cannot be changed. Pre-filter versus post-filter dilution configuration is something to be considered. We do recommend that if you want to protect your circuit, and blood clotting is one of the most common complications in CRRT, then probably a pre-filter configuration is preferred. So for those of you who might not be doing CRRT, when we are performing ultrafiltration in order to remove the uremic toxins, this is one way to remove toxins, then we have to replace the fluids that we are removing from the patient. And so we can replace these fluids either before the blood is going into the filter or after the blood is going or after the blood has come out of the filter. So we have pre-dilutional or post-dilutional configuration. And with pre-dilutional configuration, we basically dilute the blood. So that means that the risk of clotting within our circuit is actually lower. It does dilute the blood, and that means that when we are removing these solutes by convection or diffusion, we are decreasing efficiency to some extent. But in veterinary medicine, since we don't want to lose our extracorporeal circuit, this is associated with high cost and labor, we try to preserve the circuit as we can. And so for long treatment, pre-filter dilution and configuration might be preferred. So keep that in mind when you are planning your treatment. one of the major points is preventing dialysis disequilibrium syndrome, and this is a very complex syndrome. And this is the one of the most important points of the prescription. How aggressive do I want to be with my prescription? How slowly can I reduce my urea so it would be safe to prevent dialysis disequilibrium syndrome? And what we had recommended is that initially, despite of the fact that this is not a very good measure of the efficacy of the treatment, initially we need to look at the urea reduction ratio. If the patients are highly uremic, like for example 300 BUN of 300 and above, then we need to reduce urea initially very slowly. Not more than 5% urea reduction ratio per hour. If your patient is not as uremic and the BUN concentration is between 200 and 300, we can be a little bit more aggressive and have our urea reduction ratio be a little bit higher, between 5 to 7.5%, which is still very low, but a little bit higher compared to these very slow treatments. If our BUN is even lower, between 100 and 200, then we can go and have a urea reduction ratio of 7.5 to 10%. And if our BUN concentration is even lower than 100, then our urea reduction ratio can be between 10 to 15% per hour. So the more uremic the patient is, we need to be more careful and more conservative with our treatment, so we would go slowly. And the way we do that is actually by defining the effluent dose based on the BUN level. So again, we look at the BUN concentration here, and if the BUN is relatively low, you can have initial effluent dose of 1 mL per kilogram per hour. When I'm saying effluent dose, this is the overall clearance that we are providing, which can be divided by dialysis and convection. We can, in CRT or most CRT platforms, can select whether we want to remove these toxins by diffusion or by convection. But collectively, together, they will provide the effluent dose. They will determine the effluent dose. And so if your BUN concentration is relatively low, below 100 milligram per deciliter, and the risk for dialysis disequilibrium syndrome is relatively low, then we can have a relatively high dose, which is still very low compared with IHD, but relatively high dose of CRT of around 1 milliliter per kilogram per minute. If your BUN concentration is between 100 and 150, we would go slower, between 0.5 and 0.75 milliliters per kilogram per minute. If the BUN concentration is even higher, between 150 and 250, then we would even go lower, 0.3 to 0.5. Oftentimes in these patients, we would start with 0.5. But if these patients are extremely uremic, then we recommend going very slow and start effluent dose of 0.25 to 0.3 milliliters per kilogram per minute. And so this is how we calculate the initial dose to provide us with these values that are considered to be safe. So if we have a very highly uremic patient and we would start very slowly, probably we will receive, and then we have to check that, but we will end up having a urea reduction ratio of about 5%. So when we are prescribing these patients, there's the difference between conventional CRRT that you are planning to do for days and days, and then you start with a certain effluent dose, and you will go for days with the same dose. And so this is how CRRT is often prescribed in human medicine. What we are recommending for transitional CRRT is doing something else. What we are trying to do is to maximize our clearance during this relatively short period of time of 12 to 24 hours. And so the way we do that is to have dynamic dosing. We are gradually increasing the dosing. So we start very slow based on these guidelines, but we are actually increasing our dose gradually, because if we prescribe like a true or conventional CRRT, then probably after 12 to 24 hours, the patient is not going to be normalized as far as the concentration of uremic toxins. That dose is not going to be sufficient to completely normalize these patients within 12 to 24 hours. So what we are trying to achieve in this transitional therapy of 12 to 24 hours is to have complete normalization of urea, creatinine, and other solutes during this period of time. So what we are doing is basically starting very slowly, but we are adjusting the dose every 3 to 6 hours. So if we start very slowly, we would move with our dose higher and higher to maintain our efficiency. So just to explain that, and those of you who took the Hemodialysis Academy, this is an example that that I am presenting there. These are two dialyzers, A and B, that basically have the same prescription. The blood flow rate, which in that case is going to actually determine our clearance, because it's relatively low, is 50 mils per minute. Dialysate flow rate is 500 mils per minute, so blood flow rate is lower, and that is going to determine our clearance. Now we have two dialyzers of two patients. One is not that uremic, and it has urea concentration of 50 milligram per deciliter, and the other patient is highly uremic with a BUN concentration of 250 milligram per deciliter. Now you can see what are the concentration of these solutes, the BUN, before the dialyzer and after the dialyzer in patient B versus patient A. And if you were to calculate the clearance of the dialyzer based on this formula here, which is the extraction ratio of BUN multiplied by the blood flow rate, then basically these two dialyzers have identical clearance. They both provide us 40 mils per minute or 2400 mils per hour of clearance, because the extraction ratio for both of these patients is 80%. And now if we multiply that with the blood flow rate, we have a clearance of 2400 mils, 2.4 liters. But that does not mean that we had removed the same amount of toxins. So if we were to calculate how many milligrams of urea or BUN that we had removed in patient A versus patient B, you would see that the amount of solutes that we are is much higher in these patients compared to these patients, which is quite intuitive because the initial concentration is much higher. But remember that clearance itself is defined by the volume of solute that was completely cleared and not by the initial concentration. And so two patients may have the same clearance of 50 mils or 40 mils per minute, but the amount of solutes that are being removed are completely different because the inlet concentration is different. So that results in the fact that if we prescribe a very constant clearance, then the reduction of urea is going to look like that on the chart in the left hand side. And so the urea concentration is going to be much higher at the beginning of the treatment compared to the end of the treatment, because the concentration of the solute is much higher here compared to later stages of the treatment. And so if we would like to avoid this sharp drop here and to make this curve more linear, what we can do is start with a very low clearance initially when the concentration of urea is very high, And as the concentration of urea is decreasing, we are gradually and proportionally increasing the clearance. And so what we are basically achieving is a relatively constant urea reduction ratio and a linear decrease in creatinine concentration. So this is what we would like to achieve, a constant urea reduction ratio, as opposed to what we would see here with a constant clearance rate. And so when we do that, we have urea decreasing in a linear fashion, and the clearance is being increased in a linear fashion proportionately. So if you were to calculate in this example how much urea is being removed initially, because the concentration here is so high, but the clearance is relatively low, then we are removing, in this example, 12 grams per hour. As the urea is decreasing, we are increasing our clearance. And if you were to calculate at that point, in this point, how much urea we are removing, basically we are removing the same amount of urea, more clearance, but lower concentration of urea. And this is true for other parts of the treatment. So our goal is to achieve a very constant urea reduction ratio, which is going to be safe. It's going to be based on our guidelines. And we are trying to avoid sharp reduction in the early stages of the treatment. But also we are trying to achieve or maximize our efficiency during the 24-hour treatment. So at the end of the period, we would know that we had normalized all the concentration of uremic toxins. So if that's not clear, that would be a point of discussion. I'm not going to spend too much time on the fluid composition and additives. We know that our dialysate and replacement solution are going to influence directly the composition of the blood. So we are looking at sodium, which should be close to the patient's sodium concentration. We know that the phosphorus concentration, we are trying to maintain patient phosphorus concentration above 2. Potassium concentration highly depends on the blood potassium concentration. If you are familiar with the rule of 7, potassium concentration in the dialysate and in the patient should equal approximately to 7. So if your potassium concentration in the patient is 7, then you would use 0 potassium concentration in the dialysate. If the potassium concentration is 4 in the patient, we can use 3 in our dialysate. This is just kind of a very rough rule that will give us potassium concentration. And glucose, it's really important as well, especially in small patients, because in our treatments and long treatments, we are basically providing clearance of glucose as well. So it is recommended to spike the dialysate with glucose for relatively long treatments. Ultrafiltration rate, just a few words about that. We know that patients can tolerate a certain amount of ultrafiltration rate. Cats are less tolerant to ultrafiltration compared to dogs, so we are recommending going slower in cats compared to dogs. But in CRRT and in transitional CRRT, we have the advantage of a relatively long treatments, and therefore we can have a very low and safe urea ultrafiltration rate. Anticoagulation, one slide regarding anticoagulation. You can choose systemic heparinization or regional citrate anticoagulation based on your familiarity and whatever you feel comfortable, unless you have contraindication. And the main contraindication would be high risk of bleeding currently, in the past, or in the future. If you think that your patient needs to have surgery or kidney biopsy, or just had a surgery, or the patient is in DIC, then you would go with regional citrate anticoagulation and not with systemic heparinization. The main contraindication for regional citric anticoagulation would be liver failure, because the liver has to metabolize citrate. And again, this is just some of the monitoring that we are suggesting for heparin and the dosages and the adjustments. We would not spend too much time on that. This is regional citrate anticoagulation. Again, the principle here is that blood is going into our circuit. Immediately, we infuse citrate to bind the calcium, to decrease the calcium concentration to 0.2 to 0.4 millimole per liter and prevent clotting. And before the blood is going back to the patient, we would infuse calcium back into the patient. So the target would be 0.8 to 1.1 millimole per liter. Now remember that the citrate administered to the circuit and to the patient is going to be proportional to the blood flow rate and to the required citrate dose. And so if we are flowing very fast, we are going to provide a lot of citrate load on the patient, and we have to take that into consideration because there is a risk for calcium accumulation, citrate accumulation. And again, not spending too much time on that because we want to leave some time for discussion. There are a few scenarios that can happen, and you can look at that later on and see what is the desired response based on your scenario. Is ionized concentration in the patient too low? Maybe ionized concentration in our circuit is too low or too high. These are all scenarios that we will have to adjust. And in our recommendations, we had provided the appropriate response to each one of these scenarios. Monitoring, obviously, we're not going to spend any time on that. The blood pressure monitoring, machine monitoring, TMP, delta pressure are really important to prevent clotting. Remember that clotting is one of the most common complications that we have. And this is this slide here, which is talking about clotting and clogging. But again, I want to leave some time for discussion, so we're not going to spend any time on that. And that, I think, is the last slide of discontinuation and transition to medical management or to IHD. We can talk about that as well. But again, the purpose of that meeting today is not to have a lecture, but rather a discussion. So I just want to open the floor for any questions, comments regarding our CRT guidelines. Hopefully we had the chance or the opportunity to read or go through these guidelines. They are very extensive. But if there are any questions, let's just open the floor and see what kind of comments or questions we have.
Thank you, Gilad. And I was just monitoring. So we don't have any question in the chat right now, but I saw Andres raising his hand. So maybe if he wants to stop the questions.
Hi, thank you, Cedric. Yeah, I was wondering if you usually use heparin while you are priming the circuit.
So the question is if we're using heparin to prime the circuit. The answer is no, we don't. This is not part of the protocol that we're using. We're actually not doing that either in CRT or in CRT or IHD currently. We used to do that. We no longer do that. I don't know whether other institutions are still doing that, but the answer is no, we are not.
I might just elaborate. The reason that heparin was used in decades ago in priming is that the membranes that we used in the 70s and 80s and the 90s were cellulosic membranes, and those membranes had binding sites for heparin, so you could actually bind heparin onto the membrane, and that was believed to have a benefit to prevent clotting. With the advent of the modern synthetic membranes that are mostly polymer based, the heparin doesn't bind to those membranes, and so there really is no advantage or no necessity to have heparin in your priming circuit.
Thank you, Dr. Khalil. Yeah, I was wondering because in human medicine they are still using heparin to prime their circuits. At least here.
Well, I don't think there's any unique advantage to that. Unless it's a membrane that or a device that can physically attract and bind the heparin so that you've got heparin coating the material that the blood's coming in contact with.
Thanks so much for that great overview, Gilad, and for you and the group putting together these guidelines to help guide us in the right direction, if you will, and lots of overlaps with the intermittent guidelines as well. I wondered if when you talked about your priming of the circuit and that 10 to 15% blood volume threshold, if you guys considered making comments on the difference between cats and dogs in terms of that, or if you decided that they were somewhat considered equal in that regard and that threshold.
Yeah, so we did not really differentiate those very specifically, but cats, we know that cats have lower blood volume and they are more prone, because they're smaller, they are more prone to hypotension or hemodynamic adverse effects. And so we are trying to be more careful in cats and be more conservative in cats. This is true for ultrafiltration. This is true for extracorporeal volume priming. But we did not really differentiate the guidelines between dogs and cats in that respect, because it's kind of inherent in the size of the animal that cats are smaller, they are more likely to be above the 15% threshold, and more likely to have needs for some required intervention with colloid support, whether this is plasma, colloids, blood priming, or any other solution that we would need to support them hemodynamically. Again, it's mostly the colloid support. We need to remember that when we are starting the treatment, we are not changing the volume. We are removing blood and returning saline, head starch, lactated ringer, whatever solution we are returning, it's the same volume. But we know that these solutions, if they are crystalloids, they're going to be moving from the intravascular volume very quickly. And so colloid support is really important in these patients. So any comments about that? Any other questions?
I have one question. Have you usually run into the complication that the patient is moving a lot and the machine, to try to compensate for the pressure, it delivers fluid to the patient, and there's a certain amount that the patient is allowed to gain fluid before the filter says, okay, here I stop the treatment. So how do you manage that in such long treatments?
Okay, so you are specifically asking about a complication of fluid loss or fluid balance. And then when you are off the limits of the machine would discontinue the treatment, correct? Do I understand correctly the question?
Yeah, that's correct. Thank you.
Yeah, that is something that should be avoided. So these machines are constantly monitoring the volume of the patient by weighing all the fluids going in and going out. And when you define the treatment initially, you have to define what are your limits in that aspect. And we always maximize the limits. So we would not have this alarm, because when you do have this alarm, the machine discontinues the treatment, you have to replace the set, and this is very unfortunate. The movement of the patient should not cause any alarms like that. So fluid loss and gain are not affected by the fact that the patient is moving, the patient is urinating, or you have problems with your catheter. The main thing is the balance between the solution, and in my experience, the most common reasons for discontinuation of the treatment because of fluid loss or gain is the fact that someone is actually replacing a solution without specific indication to the machine. So you have to specifically indicate that you are going to change the bags, you have to remove the drawer, you have to now change your bags, and only then tell the machine, I've done that, and then the machine take that into consideration. If you are now not doing that, let's say that you are now removing your effluent bag, which is very convenient, just by placing a bucket below this bag and opening the bag without telling the machine that you had done so, then the machine doesn't know that this is actually happening. And suddenly it weighs all the solution and said the patient had lost more than 300 mils of fluids. I'm going to discontinue the treatment. So it's really important to be very careful with your changes in the bags. Every time that you are manipulating the bag, you need to do that, to tell the machine, I'm going to do that. If you are now adding additives to the dialysate or replacement solution, you have to indicate that to the machine that you're actually going to do that. Usually these additives are very slow volume. But again, we do that like we changing bags. We are indicating that we are going to change bags. We are opening the drawer. This is another indication for the machine that we are changing the bags. Now we can remove the bag, add additives, add volume, remove volume. And when we put back these bags on the machine and tell the machine that you are done your changing the bag changes that you did, you are not likely to get these alarms under these circumstances. So my recommendation would be just to be very careful and very precise when you are removing or changing bags, and that alarm should not go off just because the patient is moving or the catheter is not working.
And I would add that I feel like the machine applies more a narrow range of tolerance for smaller patient, especially if you're using a small set like the HF20. And just the power cord of any monitoring device that would be weighing on one of the bags or pushing on one of the bags could sometimes trick the machine into thinking there's some fluid loss. So you need to be very attentive to that as well. I think Jay had some more specific questions on the way you adjust your effluent dose along the treatment. If you want to elaborate on that, Jay.
Yeah, I don't perform these treatments, but I guess I was just trying to understand, like, is this, if the BUN starts at 250, like, is this predictive enough, like when you're showing those curves that you know every 3 to 6 hours you're going to go up by X amount on your effluent dose? Like, is that a known, and I don't know the consensus dialins, is that a known quantity from where you start, or is there something you're measuring along the way that's helping you make that adjustment? Just to clarify from my knowledge.
Yeah, so that is a good point. The straight answer is that you, after 3 to 6 hours, need to measure urea and BUN and adjust the dose accordingly. Having said that, it's very, very consistent. If you are starting with the recommended dosages, effluent dosages that we had recommended, and you are increasing the dose, so this is what we do, but we do check ourselves, you increase the dose in increments initially of 0.25 mils per kilogram per hour. So this would be our regular typical increment in the dose that we would do to achieve a constant URR. Obviously, there is some difference among patients, and some would respond a little bit differently, but this is what we are doing. And if you were to calculate how much we are increasing the clearance compared to the decrease in urea, you would see that this would keep us with the very same urea reduction ratio and a linear decrease in the urea. So the basic increment is 0.25 mils per kilogram per minute. But again, monitor, make sure that your patient is actually responding the way we predict.
And I think also, oh, sorry, Chet, I think also like monitoring the way the BUN comes down allows you to make sure that your treatment is going well and that, for example, you're not clogging your filter. And if it deviates from prediction, then that might be an indication that you're in trouble and you might adjust your anticoagulation or have to change your set. Which actually leads me to another question for you, Gilad. Apart from like pressure monitoring and delta P, is there any other parameter that you're monitoring during TCRT or true continuous CRT to monitor the efficiency of the filter? And uh, I know that in people, for example, when they use those filters over like 3 to 4 days, sometimes they would look at the saturation ratio or the ratio of effluent BUN on inlet BUN and make sure that stays like the same with the same effluent dose over time to document that the filter is not losing efficiency. Is it something that you would recommend or is something that you're doing in your practice?
Yeah. So this is something that we are not doing in our practice routinely, to look at these parameters in real time to know that the filter is still effective. That would be a good idea to do that. If you look at the clearance and the clearance of these dialyzers compared to our prescription, usually we are not utilizing, at least initially, most of the membrane. And so we are at equilibrium much faster, and we are probably not using initially like 80% of the membrane if you're looking at these very small dosages of 0.5, 0.75 that we are starting with our patients. And so with time, obviously, you can get clotting, but we don't typically see decrease in our efficiency. But I want to emphasize and take your question just to emphasize a point which is really important. Because people may look at the urea reduction ratio. Initially, you would see the 5%, and then you're increasing the dose. You are staying with the 5%, increasing the dose a little bit more. But as the treatment goes by, your urea concentration is decreasing and decreasing, and you are not going to increase your influent flows proportionally, because that would result in a very high dose, and a very high dose. And this is towards the later part of the treatments. And very, very high dose means a lot of fluids, a lot of bags, a lot of labor. And so we usually maximize our dose to 1.5 milliliters per kilogram per minute, and not much higher than that. So towards the end of the treatment, the urea reduction ratio is actually decreasing. And if you are doing that, if you would look at what is the difference between 20 to 24 hours, your urea reduction ratio basically may be zero, because now your inlet concentration is low, your generation rate is constant, and basically the clearance equals the generation rate. And people may look at that and say, maybe something is going on with the dialyzer. Maybe the dialyzer is completely clotting. Maybe I'm not doing anything because urea reduction ratio is zero. And if that is the case, then you need to consider whether you want to measure or not your efficiency. But usually for our 12 to 24-hour treatment, we don't feel that this is actually happening too much. We see the urea reduction ratio goes down very quickly based on our prescription. And towards the end of the treatment, it usually the urea reduction ratio at the early stages of the treatment is constant, and urea is decreasing. And towards the end of the treatment, urea reduction ratio is not really decreasing. Urea is relatively constant, and that is not a measure of decreased efficiency. If I were to do a CRT treatment for days, then Cedric, absolutely, I think it's appropriate to look at your efficiency of the dialyzer, to know that you are not just processing blood without providing any clearance. So I think for 2 to 5 days treatment, that is really appropriate. We don't think that this is necessary for our 12 to 24-hour treatment. And I would say that for the most part, we are doing something closer to the 24-hour treatment and not 12-hour treatment, because for many of these highly uremic patients, you cannot really normalize them safely within 12 hours. So our treatments are closer to the 20 hours or 24 hours.
Well, you commented on, one of the standard principles that I think we all adhere to in these CRT or transitional or otherwise prolonged, which is looking at the filtration fraction and maintaining that less than 20 or 25% to prevent clogging of those membrane pores. You touched briefly, you mentioned the post-filter hematocrit in that slide as well. And I wondered if you could comment, a little bit on using one versus the other. Are they used in combination? It seems to me at least on my platform, when I set the patient's hematocrit at the start of the session, the post-filter hematocrit that the machine delivers to me throughout maintains at a constant number regardless of what else I'm doing. So I wonder if there's a need to kind of go in there and adjust that somehow, or how do you use it practically?
Yeah, so I think we need to look at both parameters. Actually, there are some recommendations, I think, from the human side, looking mostly at the post-filter hematocrit rather than your filtration fraction. But we are trying, since clotting of the system is a big event for us, and for the clients, we are trying to prevent that in any cost. So we are looking at these two parameters in combination and maintaining these within our guidelines together. Now, sometimes, and this is, I think, unique for our setting, this is a bit challenging, especially when you look at the filtration fraction, when you're using regional citrate anticoagulation, because what we do, we have available for us, and I'm sure that this is the case for other places as well, is relatively low concentration of citrate. So if the concentration of citrate is relatively low, you have to deliver relatively a large volume. And if you are delivering a large volume, you have to filter a large volume. And so that oftentimes results in a relatively high filtration fraction in these kind of treatment. Now, you don't have a good way to overcome that, because even if you are going to make a decision, one of the ways to deal with high filtration fraction would be to have a higher blood flow rate, right? So if you have ultrafiltration and your filtration fraction is high, then blood flow rate and then your filtration fraction is going to decrease. But if you are doing regional citrate anticoagulation, actually that's not going to help, because when you increase the blood flow rate, you're proportionally increasing the citrate flow rate as well, and the filtration fraction is the same. You are just increasing the citrate load. And so that is the concern for us. We are looking at both parameters because clotting, when we did our study, clotting was the most common complication that we have, which we are trying to prevent at any cost. And so we are looking at both parameters and not only one.
On that matter, I would like to make a couple of comments if appropriate. First one is that the post-filter hematocrit that the Prismax is giving you is actually based on the patient hematocrit that you entered at the beginning of your prescription. And so it's not going to change over time unless you change the patient hematocrit in the machine, because the machine has no way to monitor the hematocrit or the PCV during the treatment. The second thing is just like I feel like we need to look at filtration fraction differently depending on if we're using pre-replacement fluid versus post-replacement fluid. Because with pre-replacement fluid, you're actually not hemoconcentrating the blood through the dialyzer, or at least you're pre-diluting and restoring the initial PCV. And so the post-filter hematocrit should be the same as the patient. And then one trick that you may consider is actually to put the crate line after your filter. And then you've got a real-time monitoring or your post-filter PCV. It gives you like less monitoring maybe of your blood volume. I mean, there are pros and cons of putting the cartridge pre and post filter, but as long as you know those limitations for both places, I mean, you can play around, or you can have two crate lines and have even more fun.
Yeah, and in that regard, it may be worth mentioning that this chamber is actually a source of clotting as well. So if you are going very long, that is another consideration to make. So you have these microclots that evolve eventually, and so that would be another consideration if you're using a cretin or not. We do not use the cretin routinely in our CRT treatments, since we are going very slowly and very gradually we feel that for the most part, we don't need that. It would be nice to have that, but the risk of clotting is something to consider as well. And so there's the balance for anything that we do, but these are very good comments, Cedric.
I think Yadir had a more specific question about the use of heparin in patients with elevated D-dimers. I don't know if Yadir is still on the call.
Yeah, hi, thank you. Is more specific for in these cases. For example, I don't have more or another things and only have heparin. And I have the I don't know how I say, but I am not sure whether I should avoid using it or use it at low doses. Or could you please guide me?
So I'm not sure I totally got the question. So the question.
I'm able to jump in briefly and bridge here. So I think what Yadir is asking in her patients that have elevated D-dimers, which I think, just to lay a foundation for the rest of us, would likely indicate that your patient is hypercoagulable and breaking down those clots at the same time. She's asking if there's any adjustments to heparin dosing that might be considered in those types of cases. So I think they're already pretty hypercoagulable, but the sounds of it.
Yeah, so I think that in those patients, when we believe that they are more prone to clotting, we would probably run with a higher ACT compared to what we would usually do. If you look at our guidelines, these are a little bit different compared to the IHD guidelines because we are recommending a higher ACT range compared to IHD to begin with. And so there is a risk going much, much higher, but those patients who are more prone to coagulation, then we would probably run the ACT a little bit higher compared to our usual treatment. You obviously need to consider other therapies as well, not only during the treatment, but also between the treatment, antiplatelets or other therapies like low molecular weight heparin or other treatments for this coagulation tendency. But during the treatment, it's mostly to run with a higher ACT range and no other difference in my opinion.
I thought I might just make a comment about ACT range. And certainly in the last 20 years, we've gotten accustomed to running ACTs for intermittent therapies at 160 seconds or something in that range. But with some of the newer therapies, with CRT, where you've got slow flows and long treatment times, or hemoabsorption, where you've got a whole different device, those require probably higher ACT ranges in order to prevent clotting. And I think we shouldn't be too afraid of that. And when we first started doing dialysis with cellulosic membranes were very, very clotty, and we routinely had to run ACTs in the 300 range just to perform intermittent treatments on those filters. And so I think you can run ACTs in those ranges pretty routinely and not be too afraid of it. These animals aren't very prone to bleeding at ACTs of 300 and or even sometimes a little higher. And so we've gotten so accustomed to this much lower range with the synthetic membranes, but all dialysis was done at much, much higher ACT ranges when we didn't have synthetic membranes. And so now that we have other therapies that we're providing that probably require greater degrees of heparinization, we're going to have to accommodate by running higher ACTs.
Thanks, Dr. Cowgill. And I think while we're on here, we should probably point out for anybody that's not familiar, Dr. Calgill is also one of the authors of the CRRT guidelines as well, and a host of other resources that he's provided for us in this extracorporeal community. With that, we are just over the 12 o'clock time frame here, and so out of respect for Gilad's time and everybody else who's joined us, Cedric and I really want to thank you guys for coming. This was great. We had, I think it looked like 50 people at one point here on the call, which is just extremely gratifying to just know that folks are here to listen, to learn from each other. And with this stepping off and with Dr. Segev's great presentation and discussion here today, we're going to hopefully continue this in one form or another on, looks like February 20th is our next session. We have some ideas for some cases we may try and share with you guys. We may continue some of these discussion points. There's plenty more to kind of keep going on with the CRT guidelines and other applications as well. If you have a case, an idea, a question, and want to join us by signing up ahead of time for a case to share, this isn't a sign up just to be there. Just show up. No need to sign up for that. Please follow this QR link here. As I said, if you can't make these sessions, they're recorded and uploaded on the ACVNU Journal Club page. And certainly would like to thank and appreciate the ACVNU and Summer, particularly for all the support that she provides for the Extracorporeal Hour and these sessions and other resources across the ACVNU. So with that, Cedric, I don't know if you've got any other closing words and
No, I just wanted to thank Gilad again for attending today and sharing his insight on these guidelines. I feel like it was like a really best to hear it firsthand from one of the authors rather than just like making our own comments. I'm very pleased with the attendance today, and I hope like a lot of you will come back for the next sessions and bring more questions or cases or anything like that. I mean, I could sit for hours just discussing around like that with people like you guys. It's just like such a pleasure. Yeah, I mean, and maybe we'll need to do a second session on the CRT guidelines in the next few months, I think, because like there's a lot of information to gather in those guidelines, a lot of details that we can dig in collectively and compare experiences and maybe have some other like tips and tricks. I see that some people are asking if they could get the slides from today, Gilad, if you would be willing to share those. We probably could send them to the whole mailing list through Summer. I think that would be great for everybody because like I think all the main information was on your slide, which is great.
Yeah, thank you very much. Thank you for inviting me here. Yeah, that was really fun to generate these guidelines because it really there was hundreds of hours of discussions with people like Larry Cargill and Terry Francais and Ariane and Kathy Langston, and so we had a lot of fun generating these guidelines as well. So thank you for the opportunity to present some of these guidelines. Hopefully that was not too fast. But there's so much to discuss, as you had mentioned. So thank you very much, and thank you for the initiative of having these rounds.
Thanks, everybody. Take good care. We'll see you in 2 weeks.
See you.
Bye.